Good evening, everyone. Let's begin today's session with Omkaram. Om. 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 Namo mantra. Natvaham kamayagyam nasvargam na punarpravam kamaye dukkadattana praninamutinasham. A warm and heartfelt welcome to all the participants of the NMO Med-Katalyst Foundation, the Zero Hour Revision Series. Today's biochemistry session. Faculty are Dr. Kiranmayi Madam, Professor of Biochemistry SVIMS, and the topics are vitamins and coenzymes. Subtopics are fat-soluble vitamins, water-soluble vitamins, coenzymes, and their functions. It is our privilege to have Dr. Kiranmayi Madam with us today. We sincerely thank you for graciously accepting our invitation, Madam. With great respect, I now request Dr. Kiranmayi Madam to kindly take over the session and guide us with your valuable insights.
Thank you, Anuja. And good evening, all of you. Hope my voice is audible clearly.
Yes, ma'am.
So, first, I'm going to discuss the vitamins. And in the vitamins, briefly, I'll go through each vitamin quickly for an overview. I cannot, because time doesn't permit us to discuss in detail all the vitamins. So, maybe in today's session, I have focused on water-soluble vitamins with a quick review on the fat-soluble vitamins. When we are discussing the water-soluble vitamins, and you will have an idea of the coenzymes also. So, commonly asked questions can be like classify vitamins. So, whenever we get a question on vitamins, so it is as it is for the other questions, brief introduction is better to give a brief introduction of the topic. For those, I have just a few points for you to write for the introduction component. There are vitamins or vital micronutrients. Because they cannot be synthesized in our body, majority of them, so they have to be obtained through diet. And vitamins are classified as broadly as water-soluble or fat-soluble vitamins. And the list of the vitamins has been given. So as we all know, water-soluble vitamins include vitamin B complex and vitamin C. Again, in the B complex vitamins, we have thiamine, riboflavin, niacin, pantothenic acid, pyridoxine, biotin, folic acid, and cobalamin. And the fat-soluble vitamins are vitamin A, B, E, and K. So most of the times, so this classified vitamins is one commonly asked question in the Viva also. So often see students fumbling to answer this question. So please answer them confidently. Classification is water-soluble and fat-soluble vitamins, and then list the fat-soluble vitamins for vitamin A, B, E, and K, and water-soluble vitamins are B complex vitamins and vitamin C. What is the difference between the two vitamins? This table shows the comparison of two types of vitamins. And again, I'm telling these slides have been taken from Vasudevan sir's textbook only. So, the water-soluble vitamins in comparison to fat-soluble vitamins, by solubility compared in fat is water-soluble vitamins are not soluble in fat, while fat-soluble vitamins are soluble. As the name itself is indicating. And water-soluble are soluble in water, while fat-soluble are not soluble in water. Absorption of water-soluble vitamins is simpler compared to those fat-soluble, that of fat-soluble vitamins. And the fat-soluble vitamins are absorbed along with the liquids, and for their absorption, they require body salts like the lipids. Because the water-soluble vitamins are soluble in the water, needing water phase, they do not require any carrier proteins for their transportation. The fat-soluble vitamins, being water insoluble, they require the help of carrier proteins for their transportation to various tissues. And water-soluble vitamins, majority of them, they're not stored in the body. The fat-soluble vitamins are stored in the body, particularly in the liver. So here you can see some star marker that is kept for some of the points because And there, the star is applicable to vitamin B12. So vitamin B12 absorption is not that simple as it is for the other B complex vitamins, and it requires a carrier protein and it is stored in the body. Then water-soluble vitamins are excreted freely, or fat-soluble vitamins are not excreted. And the deficiency manifests rapidly in case of water-soluble vitamins because they are not stored. But in the case of fat-soluble vitamins, because they are stored in the body, even when they are not taken, the deficiency symptoms will be manifested only when the stores are depleted. Until as long as the stores are there, so deficiency symptoms will not occur in case of fat-soluble vitamins. Water-soluble vitamins, as they are not stored and they can be easily excreted, the toxicity is unlikely in case of water-soluble vitamins, but in case of fat-soluble vitamins, because they are stored and they are present in the body, that hypervitaminosis is possible when doses are higher. In the treatment of deficiency, in case of water-soluble vitamins, regular dietary supply is required because it is not stored, so it has to be supplied in a regular doses. Whereas in case of fat-soluble vitamins, single large doses may prevent deficiency because once the sufficient doses are taken, it can be stored and they help in preventing the deficiency. B and C of the B complex and C of water-soluble, and then A, D, E, 4 are fat-soluble vitamins. So this gives an overview of the characteristics of the vitamins. So coming to the individual the water-soluble vitamins, so here is a list of the vitamins, the complex vitamins, and then the C, vitamin C, and the chemical name of that vitamin, and chemistry, and the active coenzyme. So this question can come like describe the chemistry, then the sources, recommended dietary allowance, then the deficiency manifestations of a particular vitamin. Question can be asked in that manner. So vitamin B1 is a thiamine. It consists of pyrimidine and thiazolidine. What you need to remember, most important, the point is important only. The active coenzyme forms of the vitamins is very important. So thiamine, pyrimidine, because in this form, the vitamins of the B complex vitamins in particular, they are playing the coenzyme functions. So thiamine, pyrimidine. Then B2 is riboflavin. It is a combination of dimethyl and D-vitamine. This, if you have already learned this, take it as a revision. Those of you who are yet to revise the vitamins topic, just get sensitized. Try to remember these chemistry components. Then the active coenzyme forms of riboflavin are two. They are clavin and adenine. Clavin adenine dinucleotide, clavin adenine mononucleotide. Then B3 is a niacin or nicotinic acid consisting of pyridine 3-carboxylic acid. And the coenzyme forms of the popular known ones, the NAD and NAD2. Then pantothenic acid is another B complex vitamin composed of pantoic acid and glutamine. Again, its active coenzyme form is very well known, coenzyme A. Then pyridoxine, another important B complex vitamin, vitamin B6, the pyridine derivative, and its active coenzyme form is pyridoxal phosphate. Remember, it is the aldehyde form. So pyridoxine can be present as a pyridoxal alcohol form, aldehyde form, or pyridoxal. But the active coenzyme form is the aldehyde form, pyridoxal phosphate, PLP. It is called it short. Biotin is another important vitamin consisting of imidazole ring with a thiophanate, and its active coenzyme form is biotin itself. It's active in the biotin form. Then folic acid is another important vitamin consisting of thyroic acid and glutamic acid. Thyroic acid is a combination of the spelling, pyridine and para-aminobenzoic acid. The coenzyme form is tetrahydrofolic acid. It will be very important to remember because so many important points we are going to discuss based on this. Then cobalamin is vitamin B12 consisting of 4 pyrrole rings with a cobalt atom. Foreign ring. It is called foreign ring. So we can compare the structure of B12 with the porphyrin ring that is present in the heme. And the coenzyme forms are in the form of adenosine B12 or methyl cobalamin. Cobalamin will play its biochemical functions. Vitamin C is chemically ascorbic acid. The structure of ascorbic acid closely resembles that of carbohydrates, and active coenzyme form is not any specific one. This is an overview. Then coming to in brief, we shall discuss each vitamin. I have tried to incorporate most or majority of the points related to each vitamin in short. So let's see them. So thiamine, we said that the active coenzyme form is a thiamine pyrophosphate. So in this form, it acts as a coenzyme for important enzymes like pyruvate dehydrogenase complex, alpha ketoglutarate dehydrogenase complex, and the transcatabase. So all these enzymes we have discussed recently while discussing the carbohydrate metabolism. So I'm sure you must be knowing PDH is catalyzing the link reaction, that is conversion of pyruvate based chemically. Alpha ketoglutarate dehydrogenase we come across in the PCS active, and both of them are almost similar multi-enzyme complexes requiring 5 coenzymes, and one of them is thiamine pyrophosphate. Then transcatabase is an enzyme of the fermentation pathway. Again, this requires thiamine pyrophosphate as its coenzyme. So hence it is a very important to remember thiamine pyrophosphate. Most of them the coenzyme functions of thiamine pyrophosphate is observed in carbohydrate metabolism. One is PDH, alpha-ketoglutarate dehydrogenase is another, and transcatabase. So these are the sources. So the sources are animal and plant products. So here are some sources of the vitamin B1. Recommended dietary allowance is 1.5 to 2. So one thing is, don't get confused between thiamine and thiamine. You know, thiamine is vitamin B1, while thiamine is what is thiamine? Comment in the chat box. The deficiency of thiamine is very. So, on short notes, sometimes the entire vitamin B1 can be asked as a short notes, or very itself can be asked as a short notes. So, very is the deficiency of manifestation of the thiamine. Wet berry present. So, types of berry are there: wet berry, dry berry, and infantile berry. Wet berry includes predominantly cardiovascular manifestations, presenting with AD, respiratory symptoms, and so on. So, predominantly cardiovascular, and it is called wet berry. Dry berry mainly presents with symptom of CNS symptoms. Infantile berry occurs in infants born to the mothers suffering from thiamine deficiency. So, here I am not given individual symptoms of wet berry, dry berry. So, just for you to quickly recapitulate and mention the types of berry. So, we need to expand that. So, most of the points, it is only quick revision, please remember, because if I go on explaining in detail, then each vitamin will take one. So, very short. Just for a quick recapitulation. Then there is the cerebral berry, which is Wernicke-Korsakoff syndrome. It consists of triad of features of ophthalmoplegia, nystagmus, cerebellar features, nystagmus, cerebellar ataxia, and psychosis. So these are the symptoms of Wernicke-Korsakoff syndrome. So here is one reason-based question. Actually, chronic alcoholics are prone for thiamine deficiency. So what is the reason? Because in alcoholics, both malnutrition, poor nutrition, as well as malabsorption, because alcohol inhibits the intestinal absorption of thiamine. Chronic alcoholics are prone for thiamine deficiency. So this can be asked as a reason-based question. So the link between alcoholism and thiamine deficiency, or the link between thiamine deficiency and disorders of carbohydrate metabolism, because we have seen how it is, but thymine as thymine pyrophosphate is important for carbohydrate metabolism. So the link between thymine and carbohydrate metabolism. And also we asked as a question. Please make a note. And then very is one of the frequently asked questions. So learn it and it so that you can stay. This figure shows the clinical manifestations of beriberi, the maybe deficiency. So when it's a syndrome, then that beriberi. So on the cardiovascular manifestations, so dyspnea, arrhythmia, then edema, it's like beriberi. Whereas dry beriberi mostly presents with CNS extensions. And the blood investigations in thymine deficiency, the thiamine level is reduced, obviously, and then but the pyruvate, alpha ketoglutarate, and the lactate levels are increased. So if we can guess why they are increased, because thymine is required in the form of thymine pyrophosphate for the metabolism of pyruvate, right? Pyruvate dehydrogenase complex, and then alpha ketoglutarate combustion also it is required. No? So for the alpha ketoglutarate dehydrogenase, since those activities, these enzyme metabolizing pyruvate and alpha ketoglutarate activities are inhibited or decreased in the thymine deficiency, these are increased. Then similarly, erythrocyte transcatalysis activity is also reduced in case of thymine deficiency. So the relation of thymine with these enzymes. Then the next vitamin, riboflavin. So riboflavin again is another vitamin having important coenzyme forms like FAD and FMN. So here is a list of FAD dependent enzymes and FMN dependent reactions. So first, I have listed out all the dehydrogenases consecutively. The succinate dehydrogenase, pyruvate PDH. So pyruvate dehydrogenase, alpha ketoglutarate dehydrogenase, we saw that they required 5 coenzymes. So one is NAD, one is FAD, then TPP, coenzyme A, and nicoamide. All these 5 are common for these both enzymes, pyruvate dehydrogenase and alpha ketoglutarate dehydrogenase. So hence in the respective vitamins, you can mention their functions. Under their functions, you can mention these 2 enzymes. So we have seen PDH and alpha ketoglutarate dehydrogenase also. Same we are seeing on the and we are going to see in the MAD section discussion also. So remember this. Then other enzymes are retinol dehydrogenase, acyl-CoA dehydrogenase, xanthine oxidase, methylene tetrahydrofolate reductase, conversion of tryptophan. So again here. So if only you are asked about the about FAD, then you need to mention these enzymes and then also mention the reactions these enzymes are better. So here again in view of the time the limitation, I have not explained reactions catalyzed by these enzymes. Then FMN dependent reactions are one is amino oxidase required amino acid oxidation. Then in the respiratory chain for the NADH dehydrogenase reaction, FMN is required. These are the FAD dependent and FMN dependent reactions. So here we can see how riboflavin is getting converted to its 2 coenzyme forms, FMN and FAD further. The sources of riboflavin are liver, dry days, egg and oil, fish, whole cereals, legumes, and grain vegetables are good sources. And for recommended dietary allowance is 2 milligram per day, and slightly higher in pregnancy, lactation, and old age is 3 milligram per day. For thymine, we have seen it as 1.5 to 2 milligram per day. Now it is 2 milligram per day. Then let's see riboflavin weekly. The deficiency manifestations. So commonly we hear about them, the glossitis, then helosis, featured with red or magenta color tone, angular stomatitis, angular mouth, with circumcorneal vascularization, duration of the bulbar conjunctival capillaries is the earliest sign, normochromic normocytic anemia, with ridges on the nose, on the nails. So these are some of the deficiency manifestations. So must remember, must The must mentionable are glossitis, meiosis, obvious, so definitely this one riboflavin. So these are the keywords. Also, suppose we get a case study on riboflavin deficiency, then we look at these keywords. Then the next vitamin is niacin, or the key coenzyme forms are the MAD and the MUBT. So many reactions are there requiring MAD as a coenzyme, and some of the MAD dependent enzymes are mentioned here. Can you just give me 1 minute and just do that? So MAD dependent enzymes are one is LDH, lactate dehydrogenase, or catalyzing pyruvate 2 lactate or lactate to bidirectional. Then glyceraldehyde 3 phosphate dehydrogenase, or again glycolytic pathway, dehydrogenase and alpha ketoglutarate dehydrogenase, as we have mentioned earlier. Others are beta hydroxyacyl dehydrogenase and glutamate dehydrogenase. This is in the amino acid. And NADP dependent enzymes are HMG-CoA reductase, conversion of methemoglobin to hemoglobin, folate reductase, phenylalanine hydroxylase. So these are some of the NADP dependent enzymes. Then again, the richest natural sources of rice polishing, liver cleanup, and these are some of the important sources of niacin. And about 50% of the requirement of niacin is met by conversion of the amino acid tryptophan to niacin. How much? 60 milligrams of tryptophan will give about 1 milligram of niacin. So again, this is important to remember. That is, tryptophan gives rise to niacin. The recommended dietary allowance is 20 milligrams per day, and in pregnancy it is 25 milligrams. Deficiency of niacin. Again, important to remember. Condition is pellagra, which is characterized by 3 days. That is diarrhea, dementia, and dermatitis. And if severe, can cause delirium and even lead to death. Then there is the dermatitis manifests in the form of increased pigmentation around the neck, which is called Cassell's necklace. MCQ or short notes can be asked in niacin, the deficiency manifestations of niacin, and along with some other additional component. What are the causes? One is the dietary deficiency of tryptophan. Example, those consuming the staple diet as maize and sorghum, they can have niacin deficiency. So we will discuss why. Again, then there is pyridoxine deficiency. For example, those on anti-sugar plus treatment with a drug called isoniazid, they are likely to develop pyridoxine deficiency, and this can result in niacin deficiency because niacin synthesis requires this pyridoxine as a coenzyme for one of the reactions. Then 2 more conditions called Hartnutt's disease, carcinoid syndrome also causes niacin deficiency. Why? In Hartnutt's disease, the tryptophan absorption from intestine is defective, and also there is increased excretion of tryptophan in the urine through kidneys in large quantities in this condition. So both of them lead to the deficiency of, because tryptophan is a major source of niacin. So in Hartnutt's disease can be deficiency of niacin. In carcinoid syndrome, what happens is the amino acid tryptophan is diverted towards the synthesis of another metabolite, serotonin, instead of getting converted to niacin. So hence, in carcinoid syndrome also, there can be niacin deficiency. So this can be asked as a reasoning-based question. Why pellagra is seen in patients with carcinoid syndrome, or why pellagra is observed in patients with Hartnutt's disease. So these are the reasons. In carcinoid syndrome, tryptophan is diverted to niacin synthesis. In Hartnutt's disease, the absorption as well as increased excretion are the reasons for deficiency of niacin. We have seen why people consuming maize as staple food are likely to develop niacin deficiency because in maize, niacin occurs in the form of niacin, which cannot be utilized by the body. There, there is a deficiency. Maize also lacks tryptophan from which niacin is synthesized. So hence, people consuming mainly maize are likely to develop niacin deficiency. Again, we have seen why people on anti-tuberculosis drug isoniazid develop niacin deficiency. What is the reason? Here, isoniazid binds with pyridoxine, vitamin B6. What happens then? B6 is required for the activity of kynureninase, which is a PLP or pyridoxal phosphate dependent enzyme in the pathway of tryptophan metabolism. So, as a result of that, the conversion of tryptophan to niacin is impaired whenever there is pyridoxine B6 deficiency. That is why patients with pyridoxine or individuals with pyridoxine deficiency can also develop niacin deficiency because pyridoxine is required in the pathway of conversion of tryptophan to niacin. So these can be asked as a reason in those questions. Then the other vitamin, pyridoxine B6, whose active coenzyme form is pyridoxal phosphate. So we observe that this vitamin pyridoxine plays a very important role in amino acid metabolism. So, for example, for the transamination reaction, pyridoxine is very, very important, and for the decarboxylation reactions in the amino acid metabolism or metabolism of sulfur-containing amino acids. So, pyridoxine is required as a pyridoxal phosphate. Remember, it is aldehyde form. Even for gene synthesis, that is for the aminolevulinic acid synthase reaction, and in the synthesis of niacin by kynureninase and glycogenolysis by phosphorylase. For these reactions also, pyridoxine is required. Again, sources. So you can remember some common sources like yeast, rice polishing, whole grains, green leafy vegetables for the complex vitamins. So you can mention commonly, remember commonly, and then any specific ones you can make a note. Then recommended dietary elements is also same as for that for timing and all in that range only 2 to 3 milligram per day. The pregnancy is slightly higher, 3 milligram per day. Pyridoxine, if consumed in excess doses, can cause toxicity. Like doses over 100 milligrams can cause a second sensory neuropathy. Is the slide changed now? Students, did this slide change now? Is mentioned in the So deficiency of pyridoxine causes neurological manifestations, dermatological manifestations. So I'm not expanded again. Said earlier, hematological manifestations. Anemia is a common in pyridoxine deficiency, and xanthorrhinic aciduria, homocystinuria will respond. These metabolic disorders will respond to B6 therapy. pyridoxine is again another commonly asked vitamin. So pyridoxine functions, remember that active coenzyme form is pyridoxal phosphate, and then the functions of pyridoxine in form of PLP for transamination, decarboxylation, and transulfuration reactions. So this is very important to mention. And then the deficiency of pyridoxine. Then what is the relation between some certain drugs and the vitamin B6? In case of IND or isonucleic acid hydroside, commonly called isoniazid, which is one of the anti-tuberculous drugs, this inhibits the formation of pyridoxal phosphate, causing B6 deficiency. Hence, B6 levels need to be monitored or supplemented whenever patients are on anti-tuberculous drug, including this drug isoniazid. Cycloserine is a D6 antagonist, hence can cause deficiency of pyridoxine. Similarly, the oral contraceptive pills usage can also cause mild B6 deficiency. And even alcohol, ethanol is converted to acetaldehyde during its metabolism after consumption, and this can inactivate pyridoxal phosphate. So hence, with all these drugs and alcohol, there can be B6 deficiency. So this reasons. Then the next vitamin is pantothenic acid, whose active coenzyme form is coenzyme A. So coenzyme A is a combination of pantothenic acid and beta-hydroxyethanol. And some important coenzyme derivatives are given here: acetyl-CoA, succinate-CoA, HMG-CoA in the cholesterol synthesis, and then also in the ketone body metabolism synthesis. Acyl-CoA, that is fatty acyl-CoA. So coenzyme A is also an important component of fatty acid synthase complex, and the acyl carrier protein of the fatty acid synthase complex also contains pantothenic acid. So these are some important functions. So as these CoA derivatives, so acetyl-CoA, which is an important molecule or essential molecule of metabolism, then succinate-CoA. So again, another important molecule which we come across on the TCA sample. So the CoA derivatives, these are the CoA derivatives. And to elaborate, mention functions of these CoA derivatives. Then sources of pantothenic acid widely distributed, and it is also synthesized by the normal bacterial flora in the intestine. Yeast, liver, and eggs are from good sources. So 5 to 10 milligram per day is the carb daily. And deficiency of pantothenic acid can cause burning food syndrome, Gopal's burning food syndrome. So one of the commonly asked MCQs for deficiency of condition of pantothenic acid, so it is burning food syndrome. Another important vitamin, biotin. So the key point with respect to biotin is biotin acts as a coenzyme for carboxylation reactions. Remember that point. And there are 3 carbon dioxide fixation reaction or carboxylation reactions that require biotin as a coenzyme. These are the acetyl-CoA carboxylase, which we come across in the fatty acid synthesis reaction, is conversion of acetyl-CoA to alanine-CoA. Then the propionate-CoA carboxylase, propionate-CoA to ethanoate-CoA, pyruvate carboxylase, pyruvate also vesicles. So these are important carboxylation reactions requiring biotin. Right? Please remember these 3. And this can be asked as an MCQ also. So the main function of biotin is biotin acts as a coenzyme for carboxylases, right? Carboxylation reactions. But then there are some carboxylation reactions which do not require biotin in our body. One is carbamoyl phosphate synthetase, then addition of carbon dioxide during urine ring synthesis, and malic enzyme converting pyruvate. These are some biotin independent carboxylation reactions. Then the recommended dietary allowance is 30 to 40 micrograms, because the synthesis by bacterial flora of the gut is usually sufficient. And this is biotin is distributed ubiquitously in plants and animals, and these are some of the rich sources. Liver is again commonly occurring in as a sources of most of the vitamins. Deficiency can occur when there is long usage of antibacterial drugs because they destroy the intestinal bacteria, bacterial flora of the gut, causing resulting in the deficiency of biotin. Symptoms of dermatitis, atopic dermatitis, anorexia, muscle pain, hyperesthesia, and hallucinations. So one of the commonly asked questions is the functions of biotin. So that is carboxylation reactions. So in MCQs as an exception, biotin independent reactions can be asked. Now, what the reasoning based question can be from biotin can be like, why does intake of raw or unboiled egg can cause biotin deficiency? So individuals consuming raw or unboiled egg can develop biotin deficiency. What is the reason? Because in egg white there is a glycoprotein known as avidin. So this protein avidin has a great affinity to biotin. Hence, it binds biotin tightly, forming an insoluble complex, preventing its absorption in the intestine. Intake of raw or unboiled egg can cause biotin deficiency because of the presence of avidin that tightly binds biotin, preventing its intestine absorption from the intestine absorption. But when it is boiled, when egg is boiled, the avidin being heat labile protein will be destroyed, and then the inhibitory activity of avidin is lost in boiled egg. So egg white contains avidin and egg yolk contains biotin. Hence, boiled egg can be a very good source of biotin because avidin, inhibitory effect of avidin is lost when boiled. So this can be again asked as a reason-based question and make it known. Another important vitamin is folic acid, and its active coenzyme form is tetrahydrofolic acid. So here, so I would like to emphasize on learning one carbon compound and their metabolism. So these one carbon compounds are actually discussed in the amino acid metabolism. Please make a note of that. So one carbon. Here I given the list of the one carbon compounds. So these are the one carbon compounds: carbonyl, carbonyl, methyl, hydroxymethyl, methyl groups. And in case of exclusively one carbon compound metabolism, so you need to mention list of the one carbon compounds. Then you mention their sources and then how they are metabolized or how they are utilized. Here, folic acid is one major carrier of the one carbon groups. And these one carbon compounds are attached or carried on the N5 and N10 of both N5 and N10 of the folic acid. So here you can see this red circle one is representing the one carbon group, and that can be attached to either to N5 or N10 of the folic acid. So here I would like to discuss few points that may be useful for you. What is folate drug? What is this folate? You see that 3 tetrahydrofolate. So this tetrahydrofolic acid, 3 tetrahydrofolate is required for DNA synthesis. But then the 3 tetrahydrofolic acid is released when its methyl tetrahydrofolic acid form transfer the methyl group to the B12. By that, vitamin B12 will get converted to methyl cobalamin and will participate in methyl transfer reactions. So, upon transferring its methyl group to B12, this methyl tetrahydrofolic acid can get converted to tetrahydrofolate and is available for important functions like DNA synthesis. What happens whenever there is vitamin B12 deficiency? Whenever there is vitamin B12 deficiency, this B12 is not available to accept the methyl group from methyl tetrahydrofolate. Hence, the methyl tetrahydrofolate is so the folic acid is trapped in the form of methyl tetrahydrofolic acid, and which is functional, not functional. So I just read out these sentences, not as with development. What is folate reactor? The free tetrahydrofolate needed for DNA synthesis is really used when 5-methyl tetrahydrofolic acid will transfer its methyl group to vitamin B12, which gets converted to methyl cobalamin. This methyl cobalamin will further transfer the methyl group to homocysteine to form methionine. When there is vitamin B12 deficiency, these reactions will stop. Hence, the cell cannot convert methyl tetrahydrofolate back to the usable tetrahydrofolate, causing methyl tetrahydrofolate to accumulate, thus trapping folate in an unusable form and leading to functional folate deficiency. This is called folate. And please remember this figure because it also helps us to understand the relation between folic acid, vitamin B12, and then the methionine or the homocysteine method. So this is very, very important to remember. Not just for biochemistry, even for your future practice also. So just to understand why patients with vitamin B12 deficiency have hyperhomocystinemia, because homocysteine is a risk factor for atherosclerosis, for coronary artery disease, for the strokes and all. So, by in the patients with vitamin B12 deficiency or in individuals with vitamin B12 deficiency, it is very important to check for the homocysteine levels because they tend to have high homocysteine levels, and the high homocysteine levels are important risk factors for atherosclerosis. So, this pathway helps us to understand the relationship between B12 and homocysteine. Again, we are going to discuss again in further slides this relationship. So I hope you all have understood what is folate dropper, which can be asked as a question, short notes, or as a reason-based question also. Again, or even folic acid can be asked as an important short notes. Folate deficiency causes of pregnancy, defective absorption, certain drugs, and then hemolytic anemia, dietary deficiency, even B12 deficiency is causing folate dropper. Then what are the manifestations of folate deficiency? Because tetrahydrofolic acid is required for DNA synthesis, they tend to reduce DNA synthesis, and then it is also manifests as macrocytic anemia, then hyperhomocystinemia, and excretion of a compound known as formiminoglutamic acid, so excretion of piglu in urine, which is the basis for the piglu test for identifying folate deficiency. And then excretion of another compound, ICAR, in the urine. I will explain again. And the folate deficiency is also known to cause birth defects, particularly neural tube defects when a pregnant woman is deficient of folic acid. Hence, it is a usual norm to supplement folic acid. Then, what is this piglu excretion test? Although this test is not done commonly or rarely done nowadays, so it is theoretically it is important to know what is this piglu excretion test, because again it can be asked as a question, or it can be short notes, not direct short notes, but can be asked as an MCQ or as a reasonable based question. So it is studying, otherwise known as histidine load test. Actually, during the metabolism of histidine, histidine is normally metabolized to what is known as formiminoglutamic acid, in short called piglu, from which formimino group is removed by tetrahydrofolic acid. So hence, in case of folate deficiency, this conversion is impaired. That is conversion of piglu to the glutamic acid by the removal of formimino group. So, and then because of the impaired conversion, the formiminoglutamic acid is accumulated and is excreted in the urine. So this piglu excretion test is hence used for diagnosing folate deficiency, because folate is required for this metabolizing the formiminoglutamic acid. Then similarly, ICAR, that is aminoimidazole carboxamide ribose phosphate, which is an intermediate in purine synthesis. Metabolism of ICAR, one of the steps of purine synthesis requires folic acid. So again, in the folate deficiency, this compound gets accumulated and is excreted in the urine. Individuals with folate deficiency. Again, another important point to note in folic acid is folate antagonists. So certain antibacterial drugs, that is sulfonamides, they act as folate antagonists. Again, this can be asked as a reasoning-based question. Also, to understand the function of these drugs, sulfonamide drugs, how do they act as antibacterial drugs? So let us try to understand. So before that, let us see the structure of folic acid. So you can see the structure of folic acid, which is chemically known as steroid glutamic acid. It consists of three components: PBD, ring, then para-amino benzoic acid, and glutamic acid. So this is the structure of folic acid. These two together called steroid acid. So in case of sulfonamide drugs, they are structurally similar to para-amino benzoic acid. So hence they quantitatively inhibit the enzyme responsible for the incorporation of GABA into the folic acid. With synthesis of folic acid, the incorporation of GABA is prevented because the sulfonamides will compete for the enzyme with GABA. And administration of these drugs, sulfonamide drugs, will inhibit the synthesis of folic acid by microorganisms, thereby inhibiting their growth. However, the synthesis of folic acid in humans is not effective. So, thus, these sulfonamides can be used as a very good antibacterial agents in human beings. So, because they are structurally similar to GABA, so they inhibit the synthesis of folic acid. Other drugs, aminoterine or amitriptyline. Amitriptyline is commonly called methotrexate, one of the important drugs. So these are anti-cancer drugs, and how do they act as anti-cancer drugs? So they are structurally similar to folic acid. Hence, they act as powerful inhibitors of the enzyme folate reductase and inhibit the synthesis of its active coenzyme form tetrahydrofolic acid. Hence, administration of these drugs will inhibit the formation of tetrahydrofolic acid, which is required for DNA synthesis. Hence, so these drugs decrease the DNA formation and cell division. Hence, are widely used as anti-cancer drugs or anti-metabolics, especially for leukemias and cardiovascular conditions. So that is how these antagonists, these drugs can act as folate antagonists and are used as a various type of drugs. So one reasoning-based question that I have come across is how does methotrexate act as an anti-cancer drug? So methotrexate or methotrexate is structurally similar to folic acid and inhibits folate reductase enzyme, which is important for which is required for the synthesis of tetrahydrofolic acid. It is a active enzyme form of folic because of the inhibition of tetrahydrofolic acid synthesis, which is required for the synthesis. So all these consequences will occur. Then the next important vitamin is vitamin B12. So here I have put the figure of the vitamin B12 absorption. So here please make a note of the role of intrinsic factor of calcium B12 absorption. So because of the deficiency of intrinsic factor can cause B12 deficiency. So if we understand the role of the intrinsic factor in B12 absorption, we will be able to answer those questions related to the intrinsic factor. Sources are B12 is not present in vegetables. Liver is the richest source. Curd is a good source because lactobacillus in curd can synthesize vitamin B12. So here these sources, observing the sources of B12 will give us a clue regarding why vitamin B12 is likely to be deficient in strict vegetarian or strict vegans. So because of its occurrence in the animal sources and deficiency in the vegetables. The diet time is 2 micrograms per day, slightly higher in frequency in lactation, that is 2.5 micrograms per day. Vitamin B12 as methyl cobalamin is mainly involved in methyl transfer reactions, like methyl methylate polyisomers, homocysteine methyl transferase. Important methyl transfer reactions are catalyzed by requiring vitamin B12. Deficiency causes are nutritional, the dietary causes decreased absorption in patients with gastric atrophy, and then Edisonian pernicious anemia, because there will be antibodies against intrinsic factor, then because of the absence of intrinsic factor, because of the antibodies, there will be impaired absorption of vitamin B12 patients with pernicious anemia. Then fish tapeworm infestation, and in pregnancy there can be B12 deficiency. So here we understand the relation between B12 and B12 system. So we see this is methionine, is sulfur containing amino acid. During its metabolism, methionine gets converted to its active form as adenosine methionine, and then which is involved in the methyl transfer reactions. So upon giving its methyl group, S-adenosine methionine gets converted to S-adenosine homocysteine, and then S-adenosine homocysteine further gets converted to homocysteine. So this is the metabolism of methionine. But then homocysteine convert back to methionine. So the difference between methionine and homocysteine is the presence of methyl group in methionine. When we add methyl group to homocysteine, this can get converted to methionine. Then who will donate methyl group to homocysteine? One important donor is methyl cobalamin. To methyl cobalamin, we donate its methyl group. We transfer the methyl group to homocysteine, which gets converted to methionine. In the return, methyl cobalamin gets converted to D12. And then this methyl cobalamin can form again, then receives methyl group from methyl tetrahydrocannabinol acid. And then this conversion will result in the formation of free tetrahydrocannabinol acid. So this is a link. We come from this side to this side. This is how we understand that. So we understand that whenever there is vitamin B12 deficiency, so there will be impaired methyl cobalamin formation, and then so because this methyl transfer reaction not occur, homocysteine conversion to methionine is not happening. Hence, there will be accumulation of homocysteine, resulting in increased levels of homocysteine in individuals with B12 deficiency. This is a reason why patients get B12 deficiency and homocysteine. Now we understand. Let us try to see the manifestations of B12 deficiency. So, simultaneous folate deficiency can occur in B12 deficiency due to folate, because B12 is not there. So the methyl tetrahydrofolate cannot transfer its methyl group. There is no receiver here. So hence this is trapped as methyl tetrahydrofolate. So tetrahydrofolate active form is not folate trapped. Then megaloblastic anemia because of the because B12 is required for the this RBC during the RBC maturation, and then high homocysteine levels again also be discussed. Then B12 deficiency can also manifest as can also have neurological manifestations because migration is not occurring properly. So demyelination and neurological lesions, and then a condition known as SACD, subacute combined degeneration. So please elaborate a subacute combined degeneration in B12 deficiency when you are learning B12. Make a note of this because one question can be like I think I'll put in the next slide. Then what are the investigations in B12 deficiency? So measuring serum B12 levels, so which is widely available in the laboratories. Then peripheral smear showing macrocytic anemia. Then increased homocysteine levels. And then there is a test known as a shielding test. The methylgallic aciduria, again because B12 is required for the metabolism of protein in folate. So the methylgallic aciduria. Then tibio excretion test for the simultaneous folate deficiency, observing B12 deficiency. So these are some investigations. So commonly are the B12 measurement, the peripheral smear, the homocysteine levels. These are commonly measured. Then methylgallic aciduria, and then tibio excretion test for test. The reasoning-based questions in relation to B12 is B12 deficiency can lead to both hematological and neurological symptoms. So why macrocytic anemia occurs in B12 deficiency? Then neurological symptoms. This is subacute combined B12 deficiency. What does it occur? So because it is required for the myelination. This the role of the B12 these two can explain in answering this question. And then again, why are strict guidelines of the discovery of B12 deficiency based on sources of B12 deficiency? We can answer this question. Then the next vitamin is ascorbic acid. What is vitamin C? Important functions are there. So one key term I can tell you about the functions of vitamin C is like biotin is required for carboxylation reactions. Vitamin C is required for most of the hydroxylation reactions in the body. The hydroxylation of protein and lysine in the collagen synthesis, and then in the tryptophan metabolism, the formation of 5-hydroxytryptophan during cerebellum synthesis, again in tyrosine metabolism also, then in iron metabolism for the reduction of ferric iron, ferric to the ferrous form, then hemoglobin metabolism, like hemoglobin to hemoglobin, and then in the folate metabolism, tetrahydrofolic acid reaction. Then during the hydroxylation reactions in bile acid synthesis, it is vitamin C is also required for the phagocytosis function, and then it is an important antioxidant. So these are some of the important functions of vitamin C. And sources, amla, that is Indian gooseberry, guava, lime, and citrus fruits and green leafy vegetables. Requirement is 75 milligrams per day. Pregnancy nutrition beverage. So deficiency manifestations of scurvy in children is infantile scurvy, also known as Barber's disease. So one vitamin C functions and the deficiency manifestations can be asked as again a short notes. And again, reasoning based question: why do individuals with vitamin C deficiency have a bleeding tendency? So we have the answers because in ascorbic acid deficiency, because vitamin C is required for the hydroxylation of protein and lysine, which is important for the during the collagen synthesis. The deficiency of vitamin C, the collagen is abnormal. The intercellular cement substance is brittle because collagen is required is important for supporting the tissues. So because of the abnormality in the collagen, the capillaries are fragile, leading to the tendency to bleed even in the minor portion. Hence, manifesting as bleeding, bleeding source in vitamin C deficiency. For example, like bleeding gums, and depending on the severity, the numeric manifestations. Then another reasoning-based question in vitamin C related to vitamin C can be like, why is vitamin C not synthesized by human beings and animals? Because the enzyme granulactone oxidase that is required for the synthesis of vitamin C is absent in the humans. And this enzyme is absent because the genes responsible for the synthesis of this enzyme is absent. So hence, not only man, higher primates, guinea pigs and bats are the only species which cannot synthesize ascorbic acid because of the deficiency or absence of this enzyme, because the gene is not present in the humans. This vitamin C cannot be synthesized by human beings. So hence, it has to be provided through diet. So these are the water-soluble vitamins. So here I have just again given the overview. That is these two table. This table also is there in the positive and surface figure. Priming pyrophosphate, then the recommended dietary, then daily, and the main reaction. Decarboxylation, alpha-keto acids, pyruvate, alpha-ketoglutarate, and the deficiency manifestation is very, very. So, KD and FMN. And the reactions, KD dependent, FMN dependent reactions, we will see, and glossitis, annular stomatitis, elosis, or the major deficiency manifestations. Important in the words. Then niacin, NAD, NADP, or the coenzyme forms, and several NAD and NADP dependent reactions are discussed, and the deficiency of niacin causes penumbra with the 3 P's as its main features. Then pyridoxine, the coenzyme form is pyridoxal phosphate, as I mentioned, aldehyde form, and important coenzyme for the PLP is important for example, transamination, decarboxylation reactions, cheeses, and the homocysteine horizon, the deficiency manifestation of a hydroxyl. Then pantothenic acid, active coenzyme form is coenzyme A, and the coenzyme A, various coenzyme A derivatives like stelpolue, cellpolue, succinylpolue, and they perform various important functions. The deficiency of pantothenic acid causes burning for syndrome. Biotin is coenzyme form is biotin only, carboxylation reaction. It is a coenzyme for carboxylases. More specific diseases given, but then dermatitis and some other features we have discussed to get mentioned them. Then folic acid, tetrahydrofolic acid is only coenzyme form. It is very one of the important functions is that it's rolling one carbon metabolism as a one carbon group carrier, then lactic anemia and other deficiency manifestations we have discussed. We can mention. Then beta, adenosine decoyl and time transfer reactions is one of the important functions of the vitamin B2, metaloplastic anemia, the acute compound vitamin B2, important manifestations. Aspartic acid has several functions, hydroxylation reactions, and the coenzyme, and also has antioxidant property. The deficiency condition is definite. For the fat-soluble vitamins, so in view of time, I'll just put the summary. And vitamin A, again, we need to discuss regarding the question how they can be asked. Vitamin A, vitamin D can be asked as essay questions. So there is a scope for them to be asked as essay questions in A and D. Again, in vitamin A, Boyle's visual cycle can be asked as a short notes, or functions of vitamin A, or functions of vitamin D can be asked by short notes. Or again, deficiency manifestations of vitamin A, vitamin D. The role of vitamins can both A and D can be asked as a short notes, or individual components like functions or deficiency manifestations of each one of them can be asked as a short notes. The functions of vitamin A are visual cycling, regulation of gene reproductive system, antioxidant, then growth and reproduction, then the skin and the mucous membranes. These are some of the important functions of vitamin A. Deficiency conditions are like blindness, talopia, then white out signs of white out spots, then xerophthalmia, dry eyes, keratoconus, skin lesions can be the deficiency manifestations of vitamin A. Then the dietary sources are meat, fish, fruits containing beta carotene. So these are some of the points about the vitamin A. Then vitamin D, cholecalciferol. The active form is calcitriol, 125 cholecalciferol, also called calcitriol, is active form of vitamin D. Then functions are major role of vitamin D is its role in the calcium homeostasis. Maintains the calcium levels by helping its absorption, and also plays an important role in the mobilization of the blood. So the action of vitamin D, when you are asked, the functions of vitamin D can be asked as a short notes. So through its effects on three important organs like intestine, bones, and kidneys. So it plays an important role in calcium homeostasis. So again, vitamin D role is also discussed in the mineral metabolism of calcium, along with other factors of calcium homeostasis, namely UPH and calcium. So vitamin D is again important in calcium metabolism. Deficiency of vitamin D causes rickets in children and osteomalacia in adults. One source is sunlight. Under the UV rays of sunlight will help in the synthesis of vitamin D in the skin from one of the intermediates of cholesterol metabolism. So that's also called sunshine vitamin. Then vitamin E is alpha tocopherol, antioxidant function, and its synergistic function with this, the trace element selenium again. So this is again understanding the relation between vitamin E and selenium is important. Deficiency can cause sterility or genetic anemia. Then the vegetable oils, dietary sources. So vitamin D. Then vitamin K, again another important vitamin. has a role in the coagulation. This can is one of I've seen this being asked as a MCQ. What is a function of vitamin K? So there is a gamma carboxylation of the glutamic acid, the clotting factors. So hence does by helping in the by causing the gamma carboxylation of the glutamic acid residues in clotting factors, so vitamin K participates in the coagulation. Coagulation deficiency of vitamin K will cause hemorrhages. So the demitigation is important dietary sources of vitamin K. Then I have put some case studies. So here is a 10-year-old boy presented to ophthalmology or reading with complaints of inability to see blackboard from a distance. A history that he often bumps into objects in the evening and has dry, scaly skin. No history of trauma or infection. On examination, child is underweight with whitish spots over the temporary conjunctiva, bilaterally dry, lustrous, cornea, and dry, scaly skin. So this is what is given in the case study. What is the probable diagnosis in this form? So here we have these key features now, but he often bumps into the object. So maybe dim vision in the night time, in the evening is said. And also can be night blindness, dry scaly skin. So this in combination with the skin features so is pointing towards vitamin A deficiency. In this case, it is xerophthalmia due to vitamin A deficiency. What is the reason for the boy bumping into objects in the evening? This is because of night blindness, also called nyctania. Because in vitamin D deficiency, poor regeneration of the visual pigment, the toxin in the retina will cause prolongation of the dark evaporation time. So so because of that, so the vision in the night time of dim light will be poor. That is called night blindness and or nyctania. And what is the reason for the dry scaly skin in the body? Because one of the functions of vitamin D is for the normal growth and the differentiation of skin cells. So many deficiency of vitamin A can cause dry scaly skin. What are the dietary? Name the dietary sources of the involved in nutrient. So animal foods are fish, liver oils, milk, eggs, plant foods or leafy vegetables of yellow, orange fruits and vegetables like carrots, papaya, mango, etc. What is the recommended dietary evidence of this nutrient? The nutrient base vitamin A and the recommended the expressed as retinol equivalents, males is 1000 retinol equivalents or 50,000 information units, females is 800 retinol equivalents or 28,000 information units. So this can be a case study on vitamin A, can be xerophthalmia or Dear students, with this session, this session is useful for you all as a quick revision, and hope you have noted some points. So you can mention in the chat so that I can know.
Ma'am,
Nisha,
ఎడ్ చేసేద్దాము.
I can. They can give their feedback. It will be useful as well. Hope it is useful. I try to quickly end up the session. And wish all the students all the very best. All the very best. And some ground rules, like I can say, they are rules only. Answer all the questions. Answer all the questions. Please don't leave any question unanswered. So if you think you will be able to answer all the questions, and then try to connect. And then you some topics are common between biochemistry and physiology. So, like for example, acids and bases, then hormone function. So make use of that knowledge. So although for it, so that you don't leave it unanswered. And then all the best. Wishing you all the very best.
Thank you, madam. Let's end the session with Shanti. सर्वे भवन्तु सुखिनः, सर्वे सन्तु निरामयाः, सर्वे भद्राणि पश्यन्तु, मा कश्चित् दुःखभाग् भवेत्. Om Shanti Shanti. Extend our heartfelt gratitude to Dr. Kiranmayi madam for an insightful session. Thank you, madam. Thank you for your valuable time. We also thank to all the participants for your presence and active participation. Thank you, madam.
Thank you.